Whoa, now that's a big burger. That burger's about as big as that guy is, and he's a big dude. If he eats that whole thing, he's going to be dealing with things that we're going to be talking about today. We're going to talk about energy health concerns and how it affects most of the people in this country, 65%. So let's talk about that. But first, we are going to tell you a little story, just in case you have any ideas about calling in sick for an exam. So this is a story about Jack and his friends. Uh, and Jack and his friends were taking a chemistry class, and they went on a trip, we'll just say to the Oregon coast, and they had a party, and they got pretty drunk, and so they decided they had an exam on Monday, so they decided that they would uh, email the professor and ask him if they could have a reprieve and maybe take the exam later. And what they told the professor is that they had went to a wedding on the Oregon coast, and it didn't get done until late Sunday evening, and they were on their way home, and they had a flat tire, and they were not able to make it to the exam on Monday because of that flat tire, because they didn't have a spare. And so they were hoping that he would allow them to take it later in the week. And so the professor said, sure, I'll let you take it later in the week and come back on Wednesday morning and we'll take the exam. So when the students got to the exam that day, the professor said, well, are you ready for the exam? They said, yeah, we've studied hard. We're ready for the exam. Uh, we were ready on Monday, but that unfortunate thing happened, and well, we won't happen again. So we're ready. So he tells the students that they are going to have to be in separate rooms because they didn't have anybody to proctor them, and they couldn't be all in the same room. So he put them in separate rooms. And then he gave each of them the exam that was in an envelope. And so he said, when you get into your room, go ahead and open the envelope, and the exam's inside. So they said, fine. So they all went their separate rooms. They opened up the exam, and here were the instructions. All questions are required. Any inconsistencies on any of the questions among the 4 students will result in all the candidates getting a 0 mark. Okay. So here was the first question. Write down your name. All right, so that was worth 2 points. Second question. Write the name of the bride and groom at the wedding you attended. Third question. What type of car were you driving? Fourth question. Which tire burst? Fifth question. Who was driving? Okay, so yeah. So anyway, we're going to talk about obesity today. And as of 2013, obesity was declared a disease. Now it is a national problem. It is a problem worldwide, actually. And so basically what this declaration means is that health insurance companies now have to cover healthcare dealing with obesity. They have to cover weight loss programs. And so if the physician prescribes a weight loss program of something specific, then the healthcare companies have to cover that. Um, I I don't know if I agree with this or not. I know obesity is a problem, but you have to think that it is preventable. People do have choices. I mean, there are instances medically that can cause obesity. There are situations, but people do have a choice of whether to eat or not to eat, and what to eat and what not to eat. So I kind of go back and forth. I understand the feeling is that we need to address this problem, and most people don't have the money to address the problem, so they need to depend on their health care. Uh, I guess if it helps, then that's great. But personally, since 2013, obesity has increased. And we've talked about uh, different situations where um, obesity has increased type 2 diabetes, it's increased cardiovascular disease, it's increased cancers. And so it hasn't made a difference. It has not reduced obesity at all. It hasn't reduced overweight at all. They're still rising. Type 2 diabetes is still rising. Cancer rates are still rising. Incidences. Heart disease risk is still rising of incidences. Now, death rates are going down because of good health care, but the incidences of their occurrence is still going up. And I have not read anything that has any indication that it has a downward trend. I believe U.S. healthcare workers are going to be dealing with this for all of your careers. How bad it's going to get, I'm not sure, but I don't think it's going to go down. And so healthcare is just going to have to deal with it. So, what is obesity? Obesity is having a very high amount of body fat. Looking at the percentage, or another way would be ranges of weight that are greater than what is generally considered healthy for a given height. That second one is a little bit vague because you could have somebody that has a lot of muscle, and for their height they may be overweight. So that's kind of vague. Um, so I think the first one would be more accurate. I remember when I was going to school, it was 20. Anybody was classified as obese if you were 20% over your ideal body weight, and that 20% was fat. So anyway, that's the definition of obesity as for the medical community. So just to give you some perspective, in U.S. adults, 65%. So that's basically, almost 2/3 of the country are overweight or obese. And then 40% of U.S. adults are obese. These came from the CDC statistics. Um, I believe, right around 2016, around in there. So 40% are obese. So it used to be, there were more overweight than obese, but now it seems like there's more obese than overweight. So people are just getting bigger and bigger. Sad thing is that children and adolescents are overweight to a high percentage, and pretty much if you are an overweight child or adolescent, you will be an overweight or obese adult. So that's kind of sad. We're getting more and more. I mean, this is just for overweight. So obesity, as I recall, in 2 to 5 years is right around 9%, something like that. So it's up there. The healthcare costs um, are really astronomical, 147 billion to deal with the healthcare costs dealing with overweight and mainly obesity. Um, so it's kind of a big deal. So let's talk about it. So I just wanted you to see this trend, and as you can see, it goes from 2008 to 2012. And looking at each of the age groups in this graphic, you'll see that every one of the age groups, except I'm not sure about what happened in the 60 to 63 year age group, went down, but every age group is going up. The one that's significantly going up the most, as you can see, is in the 36 to 43, 47, I guess, age group, where you see the biggest gap. That's the biggest change age group. But there's no age group that is basically resistant to becoming obese, and it's happening all over the world and all over the country. So it's a major problem. Okay, I want to go through these series of maps with you, starting in 1994, that basically just show what the trends are among U.S. adults in obesity rates. And you can see by the colors that there's an indication of what percentage of the population is obese. So you notice in 1994, there is no state in the 20% range at all, but you have some of the states that are in 15 to 19. Oregon still in the basically the 10 to 14% range. But as we go to 1997, what you'll see is that we start now seeing individuals in the 20% range. Uh, and Oregon kind of went up into the 15, 19, so everybody's increasing. Now, whether that's due to more uh, information that's gathered, more statistical information, I'm not sure, but it is an indication that the trend is upwards. Then we get into 2000, and you see there's lots of states. Even Oregon is in the 20% range. It seems like only, what is that state? Is that Colorado? I think so. Colorado is the only one that's down in the 10 to 14% range. 2003, now you notice the red is up to 25%. And so we've got some of the southern states, I guess that's Mississippi and Louisiana, and then West Virginia. I believe that's Indiana, maybe. My geography's not that great, but they're up in the 25% range. And then we have some other states, but even Oregon's in the 20 to 24% range. So the Midwest seems to be the best, and maybe the East. 2005, you notice again, Colorado is the lowest, but we get in. But you notice the red with the little checkers in it, basically is a 30-34% range. So that's still West Virginia and down there in Louisiana and Mississippi, I guess. Then in 2006. We're still seeing a lot more states getting up in the 25% to 29% range. 2009, greater than 30%. So we had a lot more states greater than 30%, with only Colorado again. So it looks like you want to move to Colorado if you want to lose weight. 2011. 30-35%. We're not quite to 35% yet, but we're going to get there. But a lot of states in the 25 to 30% range. 2013, there we go. We got Louisiana, no, that's not, that's Mississippi still. Mississippi and West Virginia are above 35%. I'm not sure what they eat in West Virginia, but whatever it is, it's going to their fat cells. Anyway, then 2016, uh, you'll notice we're getting into the greater than 35%. We've got more states, Mississippi, I guess that's Arkansas, and West Virginia. So the trend is upwards, my friends, and it doesn't seem to be slowing down. This is kind of interesting. I didn't know what it has to do with our class, but I just thought it was kind of interesting. It's the yearly holiday weight gain, and you can see around Christmas pretty much even Japan goes up, and you can see when people gain weight around Christmas. So that's Christmas and the New Year. So that's when all the good food is starting in Thanksgiving, I guess, which probably doesn't surprise you. But it's just kind of interesting. And I'm not sure what happens in the middle of May, but Japan, the trend, the weight gain goes up. So I don't know if there's a holiday in Japan that happens there. I'm not quite sure, but anyway, I just thought it was kind of an interesting graphic. It just makes you understand that when you get close to the holidays, you got to be really, really careful because it's easy to start gaining some weight. All right, this was kind of interesting also. The bariatric procedures are just climbing like crazy. Um, you can see that overall the total is just going up. I know there's a hospital section in Boston that is specifically for bariatric procedures. That's all they do in that section of the hospital is bariatric surgeries, and they do about 400 a month, as I understand. So they do a lot of them, but they do it the right way. They make sure the patient they don't do it right away. They make the patients and they deal mainly with morbidly obese people who are really overweight and obese, and but they make the patients wait 6 months, and then they require that they lose 10% of their body weight before they get their surgery. So they put them on a special diet, and they do, they guide them through the process. So there's counseling and everything because they don't want to do the bariatric surgery and then the person goes back to doing what they were doing, and it just kind of blows out the surgery because there's going to be some staples involved and stuff. I'll show you some examples. But you can see the two most common ones, RYGB, and I'll show you an SG sleeve gastrectomy, are the most popular. Well, let me show you what they look like. So you can see in the upper left, the Roux-en-Y type, that was the most often, where they basically use, you can see they staple the stomach, they don't take any out, and then they reconnect the small intestines to that section. And so you have a very small stomach, but you have to be careful. That's why they want them to really reduce their eating, and you eat smaller meals in several times a day, because if you eat it too much, then you can blow out those staples and get internal bleeding and all of that. But the other one on the right, which was the second most common, you see they take a big chunk out of your stomach. That's kind of scary as far as I'm concerned. But if you're morbidly obese, then maybe that's the best alternative. But you can cut that out, and then basically it just narrows the stomach a little bit, so you can't eat as much, but the stomach can stretch. And so if you eat bunches, it will stretch that stomach. So that's a problem. They need to make sure. So after surgery is a real challenge for people not to go back to their old habits and stuff. The adjustable band, not that popular anymore, where they could go in and adjust the band if, to make it bigger or smaller, kind of a thing. Um, so anyway, just thought back in the late 90s and into the 2000s, if some of you remember those times, some of you may be too young to remember those times very much, but the nutrition message was to eat low-fat foods, and people did very well at that. The problem that happened was they were substituting high carbohydrate type foods and meats in place of low fat foods. So basically people started eating more than they were. So they're eating more bulk. So as you notice today, the uh, the mantra is a lot of reducing serving sizes, and um, making sure that you don't eat as many carbohydrates, and but it's basically dealing with reducing the amount of servings of food that you eat. You can see the difference in the total pounds of food eaten between 1970 and 2017. There's 500 pounds of food on average that more that people eat. It's incredible. Um, I mean, that's a lot of food extra in a year, um, kind of thing. And then you see the calories per day. 1970, we're gaining about, you know, 500 calories a day about. And if you remember from your reading, 1 pound of fat is 3,500 calories. So if you think about that, that could be a pound a week, right? 7 times 500. Uh, so it's not surprising if we're eating that much that people are gaining a lot of weight, um, on average. And then if you look at the chart, you'll notice that every single food group has increased. And this is basically between 1970 and I believe this is 1970 to 2000. Uh, but every food group is increased. It's not just one food group, every single one. So we're just eating too much food. That's the problem. Uh, and so you don't hear as much now about the low fat message foods. You hear a lot about reducing your carbohydrates, and you hear a lot about the paleo and all that. And those to me are really extremes. We just need to eat in moderation. And you can eat anything you want in moderation and being realistic. You can't just eat a bunch of ice cream every day and think that's good for you, right? You have to be realistic, but you can eat anything. You can have ice cream, you can have fast food, but in moderation, being realistic, and knowing that it is high calorie, it's energy dense kind of thing. So anyway, that's kind of the message now, is to reduce serving size and eat in moderation. That's kind of it, because the low fat message did not work. Uh, this is kind of an interesting one. It came from 2004, National Geographic, and the whole magazine was on obesity and weight gain and stuff back then. Um, And if you look at the caption, uh, it's saying that our food is plentiful, our work is automated, our leisure is effortless, and it's killing us. Which, if you look at all those things, that's true. We have lots of food available in most cases, and you can, even if you are not making a lot of money, you can still get food. Uh, it's not a matter of and not getting the food. It's just the type of food that's cheap is very fatty and very high calorie and that kind of thing. And our work is automated. We don't do a lot of physical labor anymore. There's a low percentage of people that actually do real physical labor like they did many years ago. And our leisure is effortless. We pretty much can just sit in front of the TV and do nothing, right? Kind of a thing. And it's not doing us any favors. But that's who we are, and I seriously, again, I don't see that changing. I do not see that changing. People aren't willing to change that much. I mean, individuals maybe, you maybe individually, but collectively as a population, that's not going to change. So let's talk about obesity. There's two types of obesity uh, that can occur where the fat is stored. So I want to go over those two types of obesity and look at their characteristics and talk about them a little bit, because we will come back and relate those to those when we get to type 2 diabetes, we get to heart disease and those kind of things. So subcutaneous, if you've had anatomy and physiology, you'll remember when you studied the integument, you have the epidermis, the dermis, and then the subcutaneous layer. Well, this is where what subcutaneous obesity is when you have excess fat storage in that subcutaneous area. So it's on the outside of the body cavity and in the subcutaneous layer. If it's in the abdomen, then you have abdominal subcutaneous obesity. And that's the one that would, lop over your belt kind of a thing and be kind of jiggly kind of deal. The gluteofemoral obviously is going to be in the rear end and the upper legs, and so that's mostly, women usually store a lot of their fat in that area, kind of a thing. So we're talking about the difference between subcutaneous and visceral. So subcutaneous is outside the body cavity, visceral is going to be inside the body cavity. And if you haven't had A&P, then you'll notice the top layer of the integument or the skin is the epidermis, the dermis, and then you have the subcutaneous. So the subcutaneous is going to be filled with a lot more fat than it should have. And it's going to be kind of a loose fat, jiggly fat, Santa Claus fat, whatever you want. And so abdominal obesity would be this, a pinch an inch kind of thing that they used to say, but that is abdominal obesity. This is gluteofemoral, so it's kind of the old pear-shaped idea that you do that, but you have to be careful, especially if you have a significant other that may have this issue. You may not want to bring it to their attention. See, this guy was trying to do his significant other a favor, but as you can read, it says only moments away from putting the finishing touch on his new two-seater outhouse, Clem never knew what hit him. She was a little upset. So yeah, you need to be careful in those situations. Visceral obesity, on the other hand, is in the abdominal cavity. So it's underneath the rectus abdominis muscles, the stomach muscles, uh, and it's within the organs. So around the intestines. And if you've had anatomy and physiology, you should have learned that the gradient omentum is basically like an apron that is connected to the inferior portion of the stomach and then kind of covers over the intestines. Well, that can fill with fat. The mesentery is basically the layer of connective tissue that is holding the intestines together. So if you pull the intestines out, you would see that there's kind of a fan-like connective tissue that's holding all of those tubes together. Um, so here again, you can see the visceral fat is in the cavity underneath the muscle layer. Um, and so here is the greater omentum. You can see that it's connected to the inferior portion of the stomach, and you see it's kind of an apron that's falling over the front of the intestines. So that can fill with fat, and basically it's going to push on the muscle layer. And so here's the greater or the mesentery, so you can see it's connected, connecting all of the intestines apart together, and it can also fill with fat, right? So this would be visceral obesity, mostly occurring in men. So it's not jiggly fat. It's very hard because it's pushing out on the rectus abdominis muscle layer. This is basically the worst fat you can have. Now, eventually, most like women, like I said, is the gluteofemoral subcutaneous, but at a certain point, um, when that is full, I mean, there is a certain point where it says, okay, we need to distribute our fat somewhere else, that it will start going into becoming visceral. So women can get visceral obesity, but usually after they have the gluteofemoral has reached kind of its maximum type of thing. So visceral obesity, but men normally store viscerally, and it's been shown to be a real health risk. So we'll talk more about that later. Looking at some quotes from some researchers, basically it says carrying fat around the abdominal area has been shown to be an independent predictor of all-cause mortality in men and women. Put simply, it is more important, especially for cardiometabolic conditions, that your belt notch goes down than reading the scales. So what that's saying is that basically scales aren't that good. Scales, like bathroom scales, measure gravitational push. The more important thing is, which could be water, it could be fat, it could be a lot of things, but that doesn't solve the problem that you have visceral obesity. I just read an article, well, it was yesterday or today, I can't remember, where even if you're at normal weight and you have visceral obesity, you're at higher risk. So even you step on the scale and it looks like you're within your normal body weight, if you have visceral obesity and your stomach is sticking out because of it, you are at high risk for cardiovascular disease, type 2 diabetes, cancers, all kinds of things. So scale weight is not that indicative of whether you're doing well or not. Um, People who carry more weight in their abdomen tend to have higher amounts of visceral fat or abdominal fat, and we're going to call it visceral. And that's a much higher risk for disease such as heart disease, high cholesterol, diabetes. Um, so that comes from Dr. Lisa Giannetto at Duke University. Then another one, visceral obesity with insulin resistance and increased free fatty acid levels is associated with increased hepatic lipase activity. So you actually start getting fatty livers also in this case, which leads to removal of lipids from the LDL and HDL. We'll talk about those later in class, making them smaller and more dense, which is part of metabolic syndrome, which is considered a high risk factor. And then developing picture is that endogenous free fatty acids enhance insulin secretion in obesity insulin resistance syndromes. So it's type 2 diabetes, but eventually accumulate to toxic levels and contribute to beta cell failure. And the beta cells are going to make insulin and the development of type 2 diabetes. So this just kind of shows you where we're we're heading is looking at the kind of the upper left, about 10 o'clock or so. You'll see hepatic portal vein. You notice it's totally connected to the intestinal tract. Well, what they found is, and again, I'm kind of just giving you a overview because we'll get into a little bit later in some of the diet and disease sections, is that, when the visceral fat is broken down, the free fatty acids are going to go directly into the hepatic portal vein and directly into the liver. So that can cause, and at some point, you're going to have a bunch of free fatty acids that are going to get to toxic levels. So visceral fat is the first fat that's broken down. That's sometimes why men, if they really want to, can lose fat faster than women, because subcutaneous would be harder to lose because it's kind of the secondary energy source if you're trying to lose weight. So visceral obesity, because it's connected directly to the hepatic portal vein, will be utilized first and subcutaneous second, kind of a thing. So how do we assess obesity? Well, the most common form right now, if you go to the doctor's office, they're going to be talking BMI. So because normally they take your height and weight, and so you can tell by the formula that that's what is used to determine BMI. It is not considered a great indicator of obesity, because I'm kind of getting ahead of myself, it doesn't measure visceral obesity. It just measures weight and height. Because you can have a lot of muscle. There's a lot of weightlifters and stuff who are considered to have a high BMI, but their fat percentage is really low. So it's not a good indicator, but it is kind of a one that you can watch and see if there's a trend in the BMI. So you can use the BMI for a trend, but really by itself, it's not a good indicator of risk or anything like that. You can see the layer. I do want you to know the numbers for test purposes. So I do want you to know what the numbers for BMI would be for overweight, for obese, and extremely obese, that kind of thing, because we'll be using the terms, and if you're going into healthcare, you're going to need to know those numbers, unless they hopefully start using some other numbers. Some of the other numbers they should use. Now, if you took the BMI and you did a waist per circumference, that would be a better indicator of risk, because the BMI would, tell you kind of a weight component, but the waist circumference would tell you if you have visceral obesity or not. So that is a good indicator. I do want you to know those numbers too. I want you to know that overweight men would be greater than 40 inches and women 35 inches for their waist. The best way, though, to, if you're doing weight loss and you want to see if you're losing fat, the best way would be to do a fat percentage. Because once again, a bathroom scale is not really a good thing to trust, because what I mentioned earlier was it's gravitational push. You can lose 5 pounds, but the question would be 5 pounds of what did you lose? But most people don't care. Oh, I lost 5 pounds. Well, it could be water, right? Fat doesn't have a lot of water, but muscle does. So if you're losing muscle, you can lose a lot of water, which would show that you're losing a lot of weight. And the problem with that is that the yo-yo dieting, because people weigh themselves and they say, "Oh, I lost 5 pounds," and some of it's muscle and water, and then they gain the 5 pounds back, and it's fat. It's not water and muscle, and then they lose it again and gain it back. So the yo-yo dieting, at the end, you can be fatter than you were when you started, even though you may be at the same weight. right? So you have to be careful with that. But a fat percentage will tell you if you're losing fat or not. So they use calipers, but they can use those impedance things. Some healthcare place or what am I want to say? Exercise places can do calipers where they have the impedance where it basically have electricity going through you, and it depending on how much lean body mass you have versus fat can be an indicator of your fat percentage. But if you're trying to lose weight and you want to lose fat, knowing your percentage and seeing if the percentage goes down is a better indicator than stepping on a scale. There's a couple, we are talking about BMI plus waist circumference. So there is this a body shape index that's being promoted that is a measure of the BMI plus the weight circumference. And so it would be a good, that would be a better option, but I don't know if medical doctor's office thinks that's too invasive, that when you come in they do a waist circumference. I'm not sure if they don't want to take the time. I'm not sure if they don't they don't want to do that. I don't know why they don't. It just seems logical to me that they should do that. But especially if they're on a weight loss, if they're telling them they need to lose weight, they really need to know where that weight is coming from and if they're losing fat, kind of a thing. Again, kind of related to the body shape index is what's referred to as a waist to height ratio, is another way they can measure. And according to the medical information I've read, this is the most accurate, efficient way of identifying risk for obesity. Um, Basically, looking at the goal, adults and children should keep their waist circumference to less than 1/2 of their height. So if we look at this, you can see the weight to height ratio is waist to height, and then and I think that's pretty hard to read. I understand that's the biggest I could get. I don't know if you can expand that or not, but it does give an indication, or you can Google it, just look it up, waist to height ratio, and it gives an indication of, again, you want it to be, well, you're going to measure 1 inch above the belly button and then calculate waist to height, and you want it, half of your height. This scale kind of does that, and you can just look at the height versus the inches of your waist measurement, and you can see where it's okay is about half. So it's a good chart. But anyway, that may be the new goal, hopefully later on, where they kind of get the waist measurement into the program, right? Here's metabolic syndrome, and I'll probably introduce it again later on so you remember, because it's a critical piece. It's one of those diagnoses that if everything else seems like, if you have low cholesterol and all of that, but you have metabolic syndrome, you're just as high a risk for heart disease as if you had high cholesterol, kind of a thing. So it is an indication of risk for heart disease, type 2 diabetes, and potentially cancer and some other things. But I'll show you the cluster of symptoms. But the etiology, could be because of insulin resistance, obesity, which we're talking about, unhealthy lifestyle, hormone imbalance, any of those kind of things. But here's the risk factors: visceral obesity, which we just talked about, high triglycerides, especially in women, seem to be a critical factor. We'll talk about HDLs later, but HDLs are kind of the good guys, and they are an indicator of risk for plaque formation. Small dense LDLs are bad guys, but we'll talk about how the small dense ones are even considered a little bit higher risk factor. High blood pressure, high fasting glucose. So if the physician diagnoses you with 3 or more of these 6 risk factors, then you would be diagnosed as having metabolic syndrome. Now, if you have type 2 diabetes, that is considered a risk equivalent. So that's even higher than a risk factor. So type 2 diabetes puts you at a higher plane in this metabolic syndrome thing. So anyway, we'll come back and talk to this, but these are some, I wanted to show you this because it deals with visceral obesity that we've been talking about. So obesity is pretty complex. And so the question is, why do people get obese? Why do kids get obese? Why, what's happening kind of a thing, but it's very complex. It's kind of what they refer to as multifactorial. There's lots of things that can come into play. Uh, but the first law of fat is that basically anything you eat beyond the immediate need is going to convert to fat. So it doesn't matter if it's a carbohydrate, it doesn't matter if it is a protein or a lipid. When it gets to the liver will, if it has an abundance of sugars, the carbohydrates or proteins, amino acids, it's going to convert those into fat. Um, and then it will release that fat through what we're going to call a VLDL, and it will be deposited, in your stomach or in your visceral tissue or somewhere around there. Um, this is kind of funny. She's reading those as WW, which is Weight Watchers diet pills, but actually they're M&Ms. Okay, so make sure you read things right side up. So what causes somebody to be obese? Obviously, we know calories in, calories out. So if your calories in are above your calories out, then you are going to gain weight. That's just, there's no other way about it. But the second line of law of fat basically says that being in or out of energy balance or homeostasis, it doesn't take much to be out of balance. That's the problem. Let me just give you an example. Is let's say that you make no physical changes, you don't exercise more, you're going to live your life the way you are, but um, have heard that, well, you need, like in the winter, like now when we get flu season or something, you need extra vitamin C. So you decide, well, I'm going to just drink an extra quarter cup of orange juice 5 days a week to get some extra vitamin C to ward off the cold. So you add that. Well, a quarter cup of orange juice is about 25 calories. Okay. Well, I'm going to drink those 5 days per week. So that's 125 calories a week that you've added to your food intake. Well, you think of it, 52 weeks a year, that's 6,500 calories. So if you remember, we just mentioned that 1 pound of fat is 3,500 calories. So if you did that, you could gain almost 2 pounds a year by adding a quarter cup of orange. Now go home or I guess you may be home, but if you're, look at a quarter cup, that is not very much. It's like 2 sips. Um, and so it doesn't take a lot. Um, there are some people that say, well, I just can't lose weight. I don't eat a lot. When we eat dinner, I don't eat a lot. But then you watch them during the day and they're basically nibbling all day long. They're basically saying, well, this little bit won't matter. Uh, and sometimes when you're cooking the food, you will nibble as you cook, and then you go and you basically eaten a whole meal before you get to the meal, and then you go and sit down for lunch and you don't eat that much. You say, well, man, I don't understand, I don't eat that much at lunch. But in some people it's unconscious. If they're Thanksgiving, they're just they're just taking a little bit of turkey, and oh, I have to taste the dressing, make sure it's okay. I have to taste the potatoes, and again, they're basically eating a whole meal before they get to the dinner table. Um, and then they will nibble all day long. They'll just take a few nuts here, a few nuts there, and they don't realize how much they add up because it just doesn't seem like it's that much, but it is. And like you see here, it doesn't take that much to do that. So you have to be very conscious. Um, if you, anyway, I'll go on. So basically, if we look at the caloric balance equation, overweight and obesity is a result for energy imbalance. So we know that. But eating too many calories and not getting enough physical activity. But as I mentioned, it's multifactorial. It could be genetic. There is, a difference in percentage of nutrients absorbed between people, 25 to 75%. There can be a difference. Where some people are very efficient at absorbing things, some people are not efficient. I mean, that's not a good thing if you're trying to get nutrients in there, but for calorie wise, it's a good thing. So it's kind of a two-edged sword there. And metabolic activity, some people are more efficient at metabolizing their food than other people. And so they get all the energy out of that thing. Behavior, culture, what foods you eat, what happens, when you get together with friends and all that kind of stuff, the environment you're in, economics, usually, people that don't have a lot of money buy less expensive foods, which tend to be high fatty foods, high starchy foods, kind of a thing. Uh, there are drugs that can make you eat more, make you hungry, that kind of thing. So there's a bunch of different things. Some individuals who are really thin that have never had to worry about weight, they look at people that are big and they say, "I don't understand. Why don't they just eat less and exercise more?" Well, that's easy to say, but you don't know what's happening in their life, right? You don't know what's making them do that. It's a hard thing to do. Um, if you've never been overweight, don't get there because weight loss is not a program. A program is something that has a beginning and an ending. If you are in a position where you have to lose weight, that is going to be an issue for the rest of your life. I know that's kind of depressing, but it's something you will have to think about the rest of your life. That's kind of why when I was talking about your diet study, I was saying that it's better if you can make simple changes to the way you normally eat than to go on some type of a program, where you're taking pills or on a special diet where you buy the food. Are you going to do that the rest of your life? Because you're going to be thinking about weight loss the rest of your life. You're going to have to deal with it. It's going to have to be a major priority that you'll have to watch your nibbling. You'll have to watch everything. So you have to, make sure, that you can do it. I mean, people have started and stopped diets so many times, and I've been in places where people have all of these diet books because they'll try them all and they won't work, and they'll go to a different one, and on they go. Uh, and so, like I was saying, so if you can, did your diet study correctly and kept your food that you normally eat, then and you see that you can just make some minor changes to affect your intake, then you're more likely to stick with it and be able to do that and not have to worry about it the rest of your life. You're just going to reduce things and still have the pleasure of eating what you like to eat, kind of a thing. And then it says behavior and environment play a large role causing people to be overweight. These are the greatest areas for prevention and treatment actions. So behavior modification used to be a big deal in weight loss, where people would put their forks down and chew for longer periods of time because it takes that 20 minutes or so for you to feel full. If they always snacked in a specific chair, then the behavior modification would say you need to sit in a different chair, because when you sit in that chair, your body says, oh, it's time to snack, right? Subconsciously. And then if you buy a different chair or sit in a different chair, then your body says, oh, this is different. It's not snack time. Uh, and and so there's lots of behavior modification things you can do, but it doesn't seem to be stressed anymore. But behavior is a big deal, so you might want to think about that. And then how is obesity treated? Well, the first thing that needs to happen is, if it's you, you need to ask yourself very honest question. Am I really ready to do this? Am I ready to lose weight? Is it something that's going to be a priority for me? Am I able to do it? Because if you're not, then don't waste your time. Don't waste your time and money. Don't go see a dietitian because you'd be wasting your money because you're not ready. That should be one of the first things a dietitian asks somebody who wants to do weight loss is, are you ready to do what it's going to take? Because this is emotionally going to be one of the hardest things you'll ever do. Because you're going to be thinking about food all the time. And you're going to have to say no a lot. I can't do this. I can't. So are you really ready? And if the patient says, well, I think I'm ready, then dietitian said, no, come back when you are ready. But that doesn't happen because dietitians need to feed their families. So in my connection with dietitians, they're going to try. I mean, they're being honest. They're going to try because they think they can be successful, but they don't ask the right beginning question. Are you ready for this? Right? And you have to, because you're going to have to motivate these students. There has to be some motivation for this individual to diet and exercise, and basically exercise should be number one. If you're going to go on a weight loss process, I don't call it a program because there's no end. So if you're going to be on this weight loss process, then you need to think about exercise first. And down at the bottom, you see at least 30 minutes of moderate exercise, at least 5 times a week. So that's 150 minutes per week. That's recommended. Because exercise, when you work out and you sweat, is going to motivate you not to eat. But not eating doesn't motivate you to exercise. So exercise should actually be number one. And by exercise, I mean, getting your heart rate up and stuff. You don't hear the word exercise much anymore because it makes people, it's kind of a negative word for a lot of people because exercise makes people think about sweating and maybe pain. And they don't like to think about that. So you hear the words increase your activity, increase your movement. When in reality, it should be get off your butt and sweat a little bit. It's okay. You can carry a towel. Uh, and So exercise should be number one and diet number two, right? In that progression. But then you can do some behavior modification. But if you're morbidly obese and exercise is not, if you can't really do that because it might hurt your joints and all that kind of stuff, bouncing around and doing stuff, because aerobic exercise is the best. I mean, pumping weights is okay, but if you remember, if you've had any chemistry and in the Krebs cycle and all that stuff, you know that fatty acids go directly to acetyl-CoA, which is in the mitochondria right before the Krebs cycle. So you only, to do anything in the mitochondria, you have to be aerobic. So in order to get the fatty acids to go to acetyl-CoA, you have to be aerobic. So pumping weights is not that aerobic. So you need to be doing some heavy duty walking or anything, but if you have bad joints and stuff, it may be difficult. So you have to find some other mechanism to try to get that aerobic activity, whether it's swimming or something like that. Anyway, uh, but the rules of thumb is that weight control is going to be a lifelong effort. It's never going to go away. You're not going to get to your ideal body weight and then have to forget it, because I mean, this is kind of a sad statistic and it's kind of negative, but um, only 1% of people who say they're going to lose weight get down to their ideal body weight. And then out of those, it's pretty much less than 1% who actually, after a year, have maintained that weight. So it's pretty negative, and so it's something that you, again, are you ready to do this for the rest of your life, kind of a thing. And most people are not. That's why it's going up. They're not willing to change and make those decisions. Because it's difficult. I'm not saying it's going to be easy. It's difficult emotionally and everything else. But the realistic expectations, people want to lose that stuff. I mean, they put on their bathing suit in June and say, "Oh, I've got to lose this by July." That ain't going to happen. And if it is, probably if you do, because you can lose a lot of weight in a week, but it's mostly water. It's not fat. Because again, if you think about it, 3,500 calories, if you reduce 500 calories a day, or a mixture of reducing food intake and increasing activity or exercise, 500, that's 1 pound a week. But some people want to lose 5 pounds a week, right? That's impossible if it's fat, because that would be ridiculous. I mean, you do the math, take 3,500 times 5 and divide that by 7 and see how many calories you'd have to expend or eat less per day. You wouldn't eat anything, and you'd be walking 10 miles a day or something. It's ridiculous. So 1 pound a week is realistic, right? So that's about 500 calories a day. So that's realistic. 250 increased activity, 250 less calories. It's doable, right? Eat healthier foods, because again, you don't want to eat the energy dense foods. You want nutrient dense foods, and those kind of things. And then at least 30 minutes of moderate activity a day. Now, if you do strenuous activity, it only has to be like 20 minutes or so. But that can take some time. I mean, you have to think of the time element, especially if you go to a health club or something. You think about it, it takes you time to get there, it takes you time to dress. You do your warm-ups, then you do the 30 minutes of exercise, then you cool down, and then you go take a shower, hopefully, get dressed. I mean, that can be a 2-hour ordeal, and you may not have 2 hours 5 days a week. So that's why they say you don't have to do your 30 minutes all at once. You just kind of have to maybe you can do 3 10-minute intervals at break time or something, get your heart rate up, do some walking, park far away, unless it's night and it's dangerous, but park far away in the parking lot and walk and take the stairs, do whatever extra things you don't normally do to get that 30 minutes in and get your heart rate up and kind of thing. But 150 minutes a week is minimum. They would like people to do an hour a day. I mean, if you really want to lose that weight, it's got to be an hour a day, which can turn into a 2.5 hour a day, 2.5 hours that you'd have to give up. So, but again, before you do any of these things, you should talk to a physician and healthcare provider and make sure that physically you're ready to do that. Okay. And you don't want to get in this situation where the scale is hiding from you because it doesn't want you to step on it. So anyway, all right. So that's obesity. I hope I didn't ruin your day by being so negative, but that's the truth of it right there. All right.